Good morning. Isn't this a beautiful day?
Yeah.
You know, it's amazing how often Saturdays are so pretty and beautiful here. But you're going to not get a lot of UV for about an hour and a half now, because you're in here to hear about prostate cancer. What more would you like to hear about? I'm happy to have you here. Good to see you all. I'm in good spirits and hope you are too. And we want to be thankful for our hosts here for providing these wonderful facilities. Please help keep it clean. And they have a facility right out the back door and down the hallway. It may seem like a quarter of a mile, but it's not quite that far. So plan ahead. And let's start the program. Here's the guys that make it work. We're all dependent upon volunteers. We get no salary, but the benefits are great. Just being able to come here and help you guys and keep you informed. And if you'd like to volunteer, we're an aging group. I don't know if you noticed that. And as my wife reminds me, in 3 years, George, you're going to be 90. Now that's old. I keep saying I'm upper middle age. Like you got it, right? Upper middle age. Okay, we have a newcomer package that for you newcomers you should have gotten as you walked in. Did you get one? Every newcomer get one? It's a little information package. Fill out the front page. The front page will allow Jean here to give you a call, see if you've got any questions, and give you some encouragement, and help you get to be familiar with not only our group, but with also the disease. Now, what's our purpose? We are patient-focused. We are patients. We're experts on side effects. What all these treatments, what side effects they cause, and how to deal with those. And we've got a lot of experience we're sharing with you. The key thing is you have to be your own case manager. You're the one that says, gee, I think it's time for me to get a PSA. You need to keep a record of all your lab reports. Those are yours. Ask for a copy. Put them in a notebook. List your questions. And the second part of that paragraph emphasizes that we're not a replacement for your doctor, but what we hope we do is provide you with questions to ask your doctor. You don't necessarily get answers here, but you get questions. Ask the doctor about that. What does he think about this? What about that? And I have found that when I ask my doctor about something I've learned here, I'll ask, how about such and such? He says, yeah, we could do that. But you almost got to bring it up. See, this is a point. And because, guess how many patients he has? 3,000 or more. And hopefully he reads up off his computer about you before you come in. Sometimes they don't. Okay, for us, here's what we provide you is one is a website. And where is John Tassi? He's not here today. He's our website master. Does a great job on that. And then we have a library full of some free literature out on that table, literature you can rent, and also what you can buy. A new bestseller is the China Study. It's updated, brand new. It's not about China. And it's not about the UN. It's about cancer and the problems associated with dairy products. It turns out China has a fantastic medical basis and database and all that, and it illustrates how diet, particularly meat and dairy products, affects the occurrence not only of prostate cancer, but breast cancer. And fantastic book. And then our bestseller and the best book out there is from Mark Scholes from Prostate Cancer Oncology Group up in Marina Del Rey. The Key to Prostate Cancer. This is the Bible. This has got all the information you need in it, and it's easy to read. Recommend it for newcomers, and a good way to get updated too. Here, it's out there for sale. Okay, the next thing we have is the newsletter, and Bill, where's Bill? There we are. Bill will put in the newsletter the summary of today's meeting, or last month's meeting is in the current issue. Does a super job of summarizing it, and also Steve, where are you in terms of he's our editor of the whole document, and he's also gathers some humorous things about prostate cancers in there. Okay, outreach, an important part. You're a part of our outreach. Your friends have a high probability of having prostate cancer if you have it. Your sons have a higher probability of having prostate cancer, so remind them to get a PSA. And if you need to have somebody give a talk to your group or something, Gene and I have a snappy 20, 30-minute presentation we can give. Okay, monthly meetings. Drum roll. Richard Lamb. How many know Richard Lamb? Yeah. Isn't he a great guy? He'll come in here and he's going to talk about advances in prostate cancer. And after his talk, he grabs a chair, he sits right down there, and you're free to ask him any question. He's a wonderful person. He's my doctor up there at Marina Del Rey. He's not a urologist. He's an oncologist. He's a cancer doctor. And he's a specialist in prostate cancer. He's a specialist in doing, keeping up to date. Come on in here, speaker. He's really very knowledgeable, and he's going to be talking about advanced technology. I went to see him 2 months ago, and I qualify for a new drug called Nubequa, and it's similar to what I have been on, but with fewer side effects. I've been on Erlita, and until recently, I had to hold on to this because it has side effects, particularly vertigo. And if I turn my head from looking at you to the slide, guess what? Yes. So I've been off that for a while, and my PSA has gone up 8-fold since. I'm going to have to go back on this, but this is some new stuff. And what's different about it is it has the same effect as the one I'm on, but it has a few more molecules to it such that it won't penetrate the brain barrier. Nubeqa, N-U-B-E-Q-A. And it's just approved 3 months ago by FDA for those who have non-metastasized prostate cancer, which is what I have. It'll eventually be approved in another 5 or 6 months for those who have metastasized and so forth. But it has extra molecules attached to the chemical such that it can't go through the barrier. So it wouldn't cause vertigo for me and things like that. So hopefully it's as effective, and but without the side effects.
That's hormone therapy?
Yes, that's hormone therapy, yes. I've gone through the whole series. We're going to do a countdown here in a minute and of all the different kinds, but that's a new one. I just mentioned it from the standpoint of time marches on, and so does research. And so there's some new stuff on the horizon, and keep up to date, and you'll find out next month how things are going. So I recommend Richard Lamb. He's such a gentle person to me. After the exam and all that, he turned to me and said, how are you doing? How are you taking care of this thing emotionally? Wow. He's not only interested in my prostate, but he's also interested in my heart and my feelings. So that's the kind of doctor I want to have. Okay, we're going to do our traditional hand-raising survey of the audience, and this is for our speaker to get a profile of what we're all like, so feel free to raise your hand. How many are here for the first time? Okay, once you know you're welcome, keep coming back. I think you'll be, the name of our group starts with an I, informed, and so we'll hope you get informed here. And how many have been just recently diagnosed in the last 6 months? And you're in the mode of trying to absorb information. Last month we talked about the complexities of prostate cancer. It is a complex cancer compared to some others. Okay, how many have had prostate cancer for just up to a year? Raise your hand, please. All right. And then how many up to 4 years? We've got a few more. We're climbing that bell-shaped curve. Okay, now we're in the survival zone, 5 to 10 years. Okay, you're newcomers, look at that. Okay, 11 to 15 years. See that? See? All right, anybody above 15? All right, who's got the most? Do you have the most there, Bob?
27 years.
27 years? I got 21.
32. 17.
All right.
19.
19, see?
29.
Oh, that's Jack. I didn't see you there. He's our grand award winner. And look at, he's still smiling. Yes. Welcome back. Good to see you. Good to see you. So the program works if you do it, if you work it and follow the treatments. And now, speaking of treatments, how many have not been under treatment per se, invasive treatment, but are under active surveillance? Raise your hand. See, that's the ones that don't have the side effects. The only side effect you may have is anxiety. I wonder what the next PSA will show. But you don't go through all the other stuff that the guys that have had to go through. Number 2, surgery, prostate surgery of all kinds. I have not. Now you'll notice Gene raises his hand frequently because he's had a lot of these here. All right, radiation, raise your hand. See, now that's now the top of the curve, okay. How many are on ADT? I'm on ADT. See, this is where a lot of advances are being made. Chemotherapy, how many are on chemotherapy? 1, 2. Okay. Now we have the new treatments. New treatments, the new stuff. Okay, we're under new treatments. And give me the roll call that you've been under.
Provan, Keytruda, now on Lynparza. Or the one you just mentioned.
Xtandi, you're also been? Yeah. Yes.
All those things.
Yes. Recurrence. How many have had recurrence? See how many? What that says is be sure to keep getting your PSA. I skipped 2 years and my PSA went from 0.7 to 14. I thought I was cured. The doctor never mentioned it, and all of a sudden, wow. So keep getting that PSA. How many are undecided what to do next? Okay, see, so hopefully this will be able to help you and help you get questions to ask your doctor. I want to just now talk about the networking. What we provide here last month, if you were here last month, we had 3 of our members share with everybody what kind of treatment they had, how it felt, what side effects they had, and what they learned about it. And then after that, we broke up into separate groups along this line to have people to share and talk about their own individual treatment. That's one of the important things about prostate cancer is for us to share our experience. Not necessarily medical guidance, but just our own experience. We have Gene here who's available if you want to call up. As a newcomer or as an old-timer, give Gene a call because, as you notice, he's had a lot of experience and he can answer some of the questions or refer you to people who can. Now, last month we had a new member who had a suggestion. Why don't we create, and I call it a registry of treatment, and people who are willing to take phone calls from new members or old members about their treatment. And we're thinking about that, whether people will be willing to volunteer for that, or maybe just prefer to deal directly with Gene or come to our every third month networking meeting. How many of you are willing to put their name in a registry by treatment in case somebody wants to call? Okay, so we'll continue to explore that. How we mechanize it and ensure confidentiality needs to be worked on. But we'll probably have a meeting of our board to try to lay out some guidelines and keep you informed on that. Okay. We need your support. So it's time to pass the baskets. And these operations are not free for us. We have a reserve that helps us cover the cost. But so for us to be able to break even, we need up to $10 to break even on our operation. We're tax exempt. And so feel free to declare that. And if you need receipts, we can give you that. We accept donations, and we're not affiliated with any medical or religious organization. We're the classic 501c3. So while you're digging deep, here are the 6 reminders for managing your case. Early detection. Get frequent PSA tests. Don't do like I did. Get a high-definition diagnostic. Get a 3T MRI before you get a biopsy. So then you can see where the tumor is in the prostate, and then get a targeted biopsy. The doctor can put the needle right into that dark spot in the tumor, as opposed to just the 12 random needles. And once you get that biopsy, write down your Gleason number. If you're a 6 or lower, you're a real prime candidate for active surveillance. If you're a 7, consider that, ask your doctor about it. But then you would go beyond active surveillance into treatment, and we recommend getting second opinions. You go to a urologist, he's likely to recommend surgery. We also recommend you get a second opinion if you have a Gleason of 7, because a 3 versus a 4 is a significant tipping point. Okay, let's have our today's meeting, and we're going to kick off with Gene, has a few things to say, and then Bill Manning, who you rarely see because he's back up there, he's going to be introducing our next speaker. So welcome, and Gene, it's all yours.
I just want to expand on a couple of things. You've seen us talking about, and George mentioned that we really got to get some new faces involved consistently in our group. As George said, he's nearly old as dirt. I just passed 80. So we really got to get some people involved on a regular basis to help us keep this group going, which is one of the largest independent groups in the state of California. So we do a really good job. So give us some really hard thought about whether, if you can help us on a consistent basis. Steve, in our newsletter, he put the phone numbers of Lyle LaRoche, our president, George, and myself, to give us a call to find out what it is we do and see if you can fit into it. Secondly, and I've already gotten some results of it, in October we send out an annual mailing to help bring in additional funds to help us do all the things we try to keep on doing to help others. So you probably have already received it in the mail because I've had a lot of you guys saving a stamp, bring their donation in today. So I just want to make you aware, if you haven't seen it in your mail, watch for it, and please do what you can. As I just said, it's all tax deductible. All right, Bill, it's your turn.
Do we have the figures.
Well, good morning, everybody. Glad you could make it. We're a little behind on some of our technical issues here because I didn't provide Dr. Tamburri with precise directions on how to get here. So I'm going to accept blame for that. I'm also going to accept blame for some of the fonts on the presentation are going to be a little cattywampus. I put this together last night and everything looked fine, even on our Windows machine coming off a Mac, but it's not playing real friendly with this. So a few of the fonts are going to be not quite right, but everything else will be okay. This says when to pull the rip cord. You just don't see cord there. So, just a quick reminder, this meeting is being video recorded. It'll be transferred onto DVD. It'll be ready approximately by next meeting, maybe a little earlier. If you can't make the meeting and you'd like a copy, we do sell them on our website. It's $10, includes shipping. The DVD will have the meeting, plus it will have all the slides, plus it will also have a PDF file of the slides that you can put in your computer and actually view the slides independently. So you don't really need to go crazy taking notes during the presentation. A lot of information gets disseminated, and Dr. Tamburri disseminates a lot of information. So you might want to write down some questions to be asked later when he's done. There'll be a Q&A. And the other thing is we're going to attempt to pass a microphone around to anyone that wants to ask a question so the audience can hear what you're asking, and it also gets put onto the video. Okay, so I met Dr. Tamburri earlier this year. It was in January, and I was doing a video up at Hawaii Doc Talks in Kona, Hawaii, and I had the privilege of doing a video for Dr. Tamburri, and I found him a very great speaker, had a lot of very useful information, and we met afterwards and talked about having him come and speak to us. So we finally were able to put that together, and now we're going to have a talk on basically how to determine when that ultimate moment comes when you, particularly if you're on active surveillance, and if there's a time where you just feel that there's treatment that's now necessary, and how to help you manage that decision. So I'd just like to read a very quick little bio of him, and then I will get off the stage. Dr. Tamburri graduated from Penn State, from Kansai Gaidai in Japan, then from Southwest College of Naturopathic Medicine in Arizona, followed by his residency and chief residency in 2002. Harnessing his prior surgical allopathic training, Dr. Tamburri finished his residency and integrative training with Mayo Clinic urologists in Scottsdale, Arizona. He is medical director of the Prostate Second Opinions located in Phoenix, Scottsdale, and Seattle. Dr. Tamburri specializes in determining when a biopsy or eventual conventional treatment options are eventually necessary for the educated but surgically averse patient. So, with that, I would like to turn the stage over straight from Phoenix and finally finding the parking lot here, Dr. Tamburri.
Hey, thank you. Thank you, Buddy Patrick. All righty. All right, so I have my mic on, and
Here's a
for the floor.
for the slides.
All right, so I came in from Phoenix, well, you can tell, I'm sure, you know, Arizona. Yeah, but as in show. Came in on my motorcycle, which motorcycles and prostates, not good bedfellows. I'm the first to tell you that. But just for you, if the cops pulled me over, I bring prostates everywhere I go, including my bagger. So have prostates, we'll travel. So we'll use them for later. How many of you had seen my video, I guess that Bill did from Hawaii? I heard it's online, just to get an idea. Okay. The only reason I'm mentioning that, I didn't want to kind of reiterate everything over. So since you haven't seen that, that's fine. For those of you that are first to this organization, I'm assuming I'm probably not going to be the typical speaker you guys probably have here. So let me first get into, well, this title, When to Pull the Ripcord, is from my last year's article. I write for the peer-reviewed journal for naturopathic doctors. I recommend all of you guys check it out. Not just my article, but the journal. It's called the NDNR. It stands for Naturopathic Doctor News and Review. And you have to understand something, naturopathic physicians in more accredited states are really kind of a really good integrative balance. You know, they're not alternative doctors, they're often cross-trained, and I'll kind of explain my background in just a second to give you an idea. The problem is when you're dealing with naturopathic medicine at the level that we're at today, you can't write peer-reviewed journals that are going to be published. In other words, if you write a very peer-reviewed level article and give it to Medscape or something, they're not going to publish it because it's considered woo-woo and you're not an MD. Now they'll use our ideas and publish it themselves, but they won't publish a naturopath. So then if you publish it, let's say it's some health food journal, that's nowhere near the level, of course, and they're advertising noni juice and everything else. So where do you go in order to publish it? The NDNR is really kind of it's by naturopaths for naturopathic physicians. So check it out, and it's all kinds of things, thyroid disease and what have you. In November, they have the men's health issue, and I write the headline article each year for prostate cancer for my profession since 2007. And it's been a building series for doctors so they can start to integrate this information, especially those doctors that were not in my class. I've been a professor of urology for about, 20 years now. Geez. Torturing my students for a long time. And so many of them are out there learning some of what you're going to learn today. Now, I'm a naturopathic physician. Please be aware that I am not some alternative guy that's sitting there telling you biopsies are evil and take saw palmetto and a bunch of overpriced herbs and it's all going to go away. Okay, that is not the level of what we're dealing with here. My focus, by the way, I don't mind answering some questions afterwards, but please, the questions like, what do you think about? What do you think about, saw palmetto kind of thing? Those things are, first of all, they're generic. What you're really asking is, what do I think about an herb or supplement for you? And that's actually, first of all, a medical opinion. It's like deciding what I think about a triple bypass, for instance. But we're going to get into all that with the Q&A. But the ripcord, when to pull the ripcord, by doing this work long enough, I've realized that patients are really, at the end of the day, trying to figure out when they have a problem. But they're not sure exactly what the problem might be. So let me give you an example for those of you that, I'm sure most of you have gone through this. This is sort of the story that happens, and maybe most of you are part of this narrative. So the patient might come in and they say, hi, Dr. Tamburri. I say, hi, Mr. Smith, so why are you here? And they say, what do you mean, why am I here? I heard you're the prostate or prostrate guy. Sometimes they put an R in there, and I charge double for the R. But anyway, do I got prostate cancer, let's say? And I say, well, I'll ask why they think that. Well, half my guys only have a high PSA, and they're wondering because of this PSA thing. So we'll just go with the PSA right now. So my PSA is high. I just want to know if I have prostate cancer. And I say, okay, well, have you seen a naturopath? Yes. Have you watched Dr. Oz? Yeah, obviously. So, okay, well, have you heard that we have prostate cancer, or I'm sorry, we have cancer in us all the time? Now, most of you in this room probably have heard that we have cancer in us all the time. And so when the patient admits this, then I say, well, then why are you asking me if you have cancer? Yeah, you do. That one was easy. So then the patient says, all right, I didn't think of that. Well, do I have a real prostate cancer or not? So then I retort and I say, well, what's an unreal prostate cancer? So then they say, all right, this guy's a real wise guy. So then comes the A word. Now, I'm from Philly, so that means something else. But the A word in my office means, is it aggressive? Okay, so they keep changing the goalpost. Do I have cancer? Is it real? And now is it aggressive? Right? And I'm used to this. So I say, okay, so what's aggressive? Patient says, I don't know. I'm paying you. I want some questions answered here. So I say, okay. So I start off and say, okay, let's work with that word aggression. That word aggression does not mean what you think it means. Okay, it doesn't mean. It doesn't mean, is it bad? Is it evil? Does it have fangs? Am I going to die soon? That's not what it means. Aggression means one thing. This is a key to get started with. Period. End of story. You guys have to understand. Aggression means, anyone want to take a gander what aggression means?
Growth, rate of growth.
No. Well, kind of indirect, kind of, you're close. I'll give you half credit, yeah. Okay, it's one thing, Gleason score. That is aggression. Period, end of story, which, credit to you, because Gleason score, basically it's sort of division rate. What a Gleason score refers to is how many of your prostate cancer cells are undergoing mitotic division under high-powered field. So, if you happen to wake up in the morning and you turn to your wife and you say, you know, honey, I'm wondering how many of my prostate cancer cells are undergoing mitotic division under high-powered field, then you know what? You need yourself a Gleason score, and you get a score. You get a score between 6 to 10. I'm sure you guys know this by now. And then then the patient says, well, what happened to 1 to 5? I want to get one of those. But, you know, it goes from 6 to 10. Okay, well, then now you got a 7. They have a 7. Congratulations. You want to know what your aggression is, you have a 7, and maybe an 8 or whatever. It's a 3 plus 4, even 2 more little numbers you have. I mean, I could get into the details of that, but at the end of the day, now's your 7. Now, what are you going to do with that? Put it on your Facebook, show your friends? I mean, what does a 7 do? How does it move the needle? And what I'm trying to get to is that guys go through this endless quest of going from test to test to test, trying to tell them something. But often, if you don't know what the question is, you won't get to the answer. And so therefore, the importance is understanding when we're saying the word aggression, understand that your urologist sees aggression as a legal term for Gleason score, which is something they have to have in order to move forward with your case. Okay, they have to have that Gleason score on that slide. So if you sue them later, then they can show the judge. That is why imaging is not legally binding, and we'll get to the MRI issue sometime later. That's why they will do everything to convince you to get that biopsy so that they have that cell, because they will not operate. Your insurance company will not pay the doctor until they have that cell so they won't be sued. And his malpractice insurance, you know, because of Goldberg and Osborne trying to sue him, the whole situation is predicated off that biopsy to show the judge. So therefore, that is the definition really for aggression. So it's the only thing, I'm not really politically correct, you guys can probably tell, plus I'm from Arizona, but the only time I get PC is over that term aggression for legal reasons and just for making sure that my patients and I are having the same conversation. So that word aggression I banned almost from my office. Now aggression means biopsy, and if they just want to know is it aggressive, I say go get a biopsy. And half of my guys are there because they refuse the biopsy. They don't want it for other reasons. So even if they have a biopsy, they have their number, but still they're at the same position. Well, what does a 7 mean? What does it really mean to me? You know, just the doctor says it's a problem. So therefore, what I encourage patients is to redefine the question. Don't say, is it aggressive? Redefine what your question is. I mean, what is the goal? And I throw that to patients because it's something that, it sounds like an obvious thing, but it gets complicated. It's like pulling the thread and it keeps going. I mean, what is the question? And I know for each of you it's a little bit different because there are different, you know, the journeys here, you know, the different parts of that journey. But is the question, do I got cancer, right? Is the question, is it legally aggressive? Okay, we'll start there, you know. Is the question, why is my PSA high? Maybe the question is, do I have a cancer that's going to kill me? If it's going to kill me, well, how does it kill me? Well, only if the cancer gets out. So maybe your question is the cancer out or not? And if the cancer is not out, then you're going to switch and say, okay, well, if it's not out, well, how long do I have until it gets out, right? Or maybe the question is, why do I have symptoms? Or maybe, you know, for those of you that don't have symptoms, that's even more, probably a greater problem, actually. And then some men will come in and ask about erections. The irony is erections has nothing to do with the prostate. They're actually separate. It has nothing to do with it. ED, and just for the record, I'm going to get this part over, because a lot of people will ask that. ED, it has nothing to do with urology, oddly enough. It's a secondary effect from everything else, okay? So the #1 cause of ED is diabetes, right? That's not a urology issue, typically. I mean, they should be able to treat it, but they don't, right? How about polypharmacy, if you're taking too many drugs? Okay, that's just too many doctors. Is it, another #2 cause is actually cardiovascular. Okay, that means a cardiologist. That's not the urologist. Often it's psychosomatic, depression or anxiety on top of the prior. That means a psychiatrist. I'm not telling you to go do that. I'm just saying, I'm just pointing out that if you think about it, ED is always a side effect of something else. And that's why, or hormones, low testosterone, of course. That's the endocrinologist. So ED is usually a secondary issue to something else, even though I see patients come in for it. The irony is, though, I don't like to take too many digs at my urology friends because I do party with them, but There is one case of ED, and that is ED by urologist. Okay, that is by removing your prostate, and perhaps for the wrong reasons, that can cause ED. So the irony is, the person that we go to fix ED is probably the only really link to it is that they can cause it if you have unnecessary surgery. So again, that's not a cheap shot with them. I do recommend surgery and biopsy, radiation all the time, probably more than any naturopath that you'll ever meet. But I just want to put that in perspective for some of you that are wrestling with ED, that there's, it's connected, but not quite the way people often think. The other link with ED is testosterone. A lot of guys are taking testosterone for ED, but then there's the whole, it's like the abortion debate. That's how crazy it is in my field regarding does testosterone cause prostate cancer or not, and that's a whole other thing. Maybe if you have questions, we can talk about that next time or after in the Q&A. But anyway, what guys are ultimately getting to is, after trying to go through all those questions, well, is it a problem? What's a problem? Trying to define it. What's aggressive? What am I really here for? And of course, then they want treatments, but you can't get to the treatment until you know what you're treating. Well, I just told you, doc, I got cancer. Yeah, I know there's cancer, but are we treating the cancer? Or are we treating the PSA? These are different things. I've had patients, for instance, just to give you a quick example, I had a gentleman who was this good dentist, and this is a quick story, and then we're going to get into these PowerPoints, although I just kind of riff off of these. I don't do book and record, just so you guys know. But this is a good case to get started with. I had a gentleman, the dentist, he was semi-retired at age 50-something. His last child went off to college, and he told his wife, I either now can buy a motorcycle or a divorce, you pick, all right? So she said, all right, fine. So he wound up getting the motorcycle, but the quid pro quo, he had to get a life insurance policy. This comes in later. So anyway, so he gets his hog. Now, of course, older guys, when they get a motorcycle, they don't start off with a dirt bike. They get like their cupcake, like this thing outside, and they start off in this giant monster, and he starts going cross country, playing like an Easy Rider, Dennis Hopper thing, and he goes from California on his way to Maine. He made it as far as Chicago, at which point his prostate seized up. Okay, because for those of you that ride motorcycles, it's not just the fact that it vibrates, because they don't vibrate anymore. That sucker's got a suspension better than like a Mercedes. I mean, it's like a flying carpet. But the problem is when you ride a motorcycle, just to give you guys some perspective, you can't just lean back when you're riding for 5 hours at a time and move your weight around, right? A motorcycle, you have to be focused at all times for hours. And riding a motorcycle is very fun, so time flies. It's like being on the computer sometimes. You're just like this. The point is you're right over that prostate, and you're not moving. You're not moving your weight around. So that prostate is just squeezed and being pressured. The PSA can spike up, all sorts of things. So doing that cross country when you're not used to it, his prostate eventually seized up, and then he couldn't urinate. So he had to go to the ER, and then you had I think you had like Nurse Ratchet walked in, and she took the catheter and shoved it up, and it then got to a jammed prostate, and right? I know it's too early for this discussion for some of you, and shoved it through. Right? Then they took his blood and his PSA. Now what do you, oh yeah, are you kidding me? I've seen everything. So all of a sudden his PSA comes back like 16, right? Oh, stop the presses. If they just stop your trip, go to a urologist. He had to get a biopsy and the urologist, do you think they actually ask a history? How long was the history taken when you guys saw the urologist for the first time? How much did they ask you about your background and everything? They just, they barely, probably, all they do is they look at your PSA, and if it's black, they go, okay, let's biopsy, right? So they biopsied him. They found of 12 cores, 1 core out of 12, that core was Gleason 633, and it was less than 1% of the 1 core, okay? And then they told him to have a radical. Right? He was all set to have one of the first Da Vinci's some time ago, right? So his wife saw me. I gave a speech at the Mayo Clinic at home, and his wife dragged him in, and of course he's like, why are we seeing this quack? I don't understand why I have to go see this, honey. I have PSA 16, and I have cancer. What's there to talk about, right? So eventually, of course, the two of us, the patient and I are good buddies now, but we went through it, and of course, what I just told you took me an hour to get through the case to figure out everything I just told you. See, this was not brought up. There's just a PSA and a biopsy. So I asked a stupid question. I said, okay, well, did anyone ask you this story? He said, no. I said, okay, I'm going to ask a really interesting question that I'm afraid to know the answer. I said, do you happen to know, or did anyone ask you what the PSA was before the trip? He said, no. But, remember his wife? His wife made him get a life insurance policy right before, a whole panel of labs. 2 weeks before the trip, it was 1.3, okay? 1.3 to 16 in 2 weeks, that ain't cancer. That's called a hog. And a really nice one, I might add. He had a nice, he was a road king. But the thing is, that gives you an example. Now, some of you might say, okay, well, does it matter? Because, well, they found cancer, and isn't cancer bad? Yeah, but the point is, the cancer was there when it was 1. So therefore, this is what I mean. What is the question? Is the question, do I have cancer? Well, first, we all have it anyway. Is the question, does he have it legally? Yes, he does. Is it aggressive? Well, it's a 6, and we'll talk about 6 at the end. That's some brand new information in the first class here. I'll be talking about this one. Bill, the thing at the PCRI, they talked about Gleason 6. Is it cancer or not? Very interesting discussion. We'll see. We'll talk with you guys about it. But anyway, so that's the thing. Like, what is the question? Does he have cancer? Yes. Is it legal? Yes. Is that why the PSA went up? No. So then what are we treating? And if we have cancer in us all the time, well then what is the point? What are we doing? And this is why I get so specific. Sometimes I kind of annoy some of my patients at first because they don't understand why I get so detailed. Just, it's right here. It's in the pages. It's right here. Here's the biopsy. Just point to it. But because the case often is in the history and with the patient understanding what they're doing, what their perspective is, what are their goals? Do they prefer quality of life or longevity of life? That's a huge difference. It changes the case remarkably because you're not a number. It comes down to you as the patient and the personality, and as we'll see as we start going through some of these. So prostate ping pong, and your prostate's the ball, okay? I'm sure you guys feel like it sometimes. You have the conventional guy who says, PSA is over 4, get a biopsy. Now they're getting a little better, I'll give some credit to them, but over 4, get a biopsy. If the biopsy comes back positive, oh, well, what are you doing next Tuesday? We'll rip it out, freeze it, nuke it. They're very creative. And by the way, I do refer patients to these for these techniques. There are some really great techniques and procedures out there. So I don't want any of you to get the idea that I'm some anti-conventional medicine. I'm the opposite. It's kind of like being libertarian. Conservatives think you're liberal and liberals think you're conservative. You have no friends. That's how it is also when you happen to be a naturopath of what I do. Because the conventional doctors think I'm a quack automatically, and my alternative friends think I'm too conventional. So no one comes to my birthday. That's what happens. But anyway, but for you guys, this is the situation you have. And there's a famous book. How many of you read Invasion of the Prostate Snatchers? Great book. And the first edition cover shows 2 fists of a surgeon and a businessman, an alternative person at fisticuffs. And that is what most of you get caught in, and that's what my office is trying to kind of unravel. So that's the prostate ping pong game. So again, biopsy, PSA's high, biopsy, surgery, what are you waiting for? And the alternative guy says the opposite. What are you doing? PSAs aren't reliable, throw them out. Then I get patients coming up with PSAs of 3,000 telling me that they don't believe in PSA because the website told them. Then, or never get a biopsy, it's going to spread the cancer and you're going to die. There's no evidence for that, by the way, and that's a whole other issue. And I'm the natural guy. We can talk about that as far as you could spread the cancer throughout the prostate itself. That's possible. But like the Heisenberg uncertainty principle for some of you geeks out there, you'll never actually know. You might spread throughout the prostate, which creates a problem if you're going to biopsy and then not commit to the conventional. Because one locus of cancer could turn into 2 or 3 that now you have to treat naturally. That's conceivable. But as far as the cancer getting out and spreading around your body and dying early, there's no evidence for that. And I can prove that part just very quickly. I usually have a whole graph that I show. But just think about this, because you guys are the advanced class, Bill's telling me. You guys have been doing this for a while. Think about it, that the PSA, when the PSA was introduced, you had a spike in prostate cancer diagnosis, right? Why did that happen? It's because they started biopsying everyone because of the motorcycle or a whole bunch of other reasons, right? Well, if biopsy spread the cancer to the point that you die, then when you began to spike the diagnosis of cancer, because all these biopsies were done, then you should concomitantly have seen an increase in the mortality rate of prostate cancer from the spread. Instead, we see a marked decrease. Now, I don't say it's too marked. It's statistically significant, and that's because of taking everyone's prostate out. It's like if every woman, by the time they turned 45, we did a double mastectomy, the breast cancer rates would go down, and we would call that a success. At least the MDs would. That's what we're doing to our men. We're removing prostates perhaps that we shouldn't too much, and then when the mortality rate goes down a bit, they call that evidence that it works, and it kind of is. But for every prostate we're taking out that people have side effects, you're having how many more that have quality of life issues? And that's the game, that's the problem. It's like Spock talked about, the needs of the many outweigh the needs of the few or the one. And that's really what the medical system's trying to figure out. So that's prostate ping pong, and that tends to be where my patients are. And probably many of you, if you're not in it, I'm sure you've been in it already or you're figuring it out now. I mentioned this earlier. You'll never know your answer until you understand the question. I lived at a Buddhist monastery for some time when I was in Japan and learned quite a bit about not just medicine and spirituality, but myself as well. Hence the ponytail, that's where it comes from. But so that's another story. But much of my medicine I learned from them. Studying in spirituality in a sense, Judeo-Christian faiths, if you just the Bible itself, for instance, it's more like the eye for an eye. It's more, it's different. It's like good versus bad in many ways. I'm oversimplifying, of course. Whereas Buddhism is more just allow things to be whatever they are, and it's sort of like a keto. The martial arts Aikido. It's twice the damage, half the effort. You don't punch back. You just bring the person in and deflect, and that's sort of medically how I approach things. Instead of, here's the cancer, what do we do? We have to kill it, we have to destroy it. And I don't want chemotherapy, doc, because there's some herb that kills it and destroys it, And that may not be always what you're trying to do. What is the goal of natural treatments? Is it really to kill the cancer? I got news for you. Most natural treatments do not kill cancer. That's usually not what the goal of natural treatments are. It's not to kill cancer. There's a couple we think, vitamin C IVs and things, but that's not really what natural treatments do. Natural treatments really are to promote and build up your own body so it can take on the cancer and it can isolate it and you can outlive it. So therefore, that's the other question. When I say, what is your goal? Is your goal to kill the cancer when it's dead and gone? Or is it to just die of a heart attack in Las Vegas in 20 years? That might be what your goal is, not to die of the prostate cancer. You know what I mean? So I'm just being realistic, is that what is the goal? And if the goal is to outlive it, then like the old saying is, if you and I are chased by a bear, I don't have to outrun the bear, I just have to outrun you, right? And so therefore, if I just outrun the cancer and die of something else, maybe that's the goal. And I'm being serious when my guys kind of get that, it coincides with the idea that we have cancer all the time, and learning to live with cancer is often the treatment, not fighting it and destroying it. If you want to do that, there's called chemotherapy. They'll destroy the cancer, but a lot of other things along with it. So that's sort of the quid pro quo you have to kind of work with. Does this kind of make sense? If I'm talking too quick, just let me know. I get in my Philly Italian mode and I talk quick. All right. And just put a similar quote there. All right, so prostate perlusa. Let's see what we have here. So the prostate ping pong, biopsy safety, does it spread the cancer? I had touched on some of these already. Oh, and by the way, Bill, if you're his timekeeper, can you just let me know when I have 15 minutes or 10 minutes beforehand to wrap up, if you can, before we get to Q&A? I appreciate that. Current prostate MRI imaging utility. That's sort of the new fad now. And by the way, at my office, because all we do is active surveillance assessing. That's just give you an example of what I do. When patients come in, they usually bring their wife in, which is good, and I see a lot of the wives here, which is excellent, because when it comes to prostate cancer, I don't have one patient, I have two, all right? I have two. Sometimes they're on the same page, sometimes they're not. And that makes a big difference, because if you're doing active surveillance, that's not a we call it a sprint, it's a marathon. And you need help, and you have to make sure that both parties are together. It's not always the case. Sometimes I see, sometimes the wife, she'll be, the husband wants to save his erection and doesn't want the doctor to touch him, and the wife is saying, Harold, stop being stubborn and get the damn thing out already. What are you doing? We don't want you to die. And then I get the opposite. I have the guys, maybe the hormones are different, and the couples is not having sex. And then, the husband just wants to play golf, and the wife's all into natural medicine, and she's dragging her husband around, try this, try this, try this. So those are the two extremes, and most people are somewhere in between. But my point is that that's part of the dynamic of the treatment. I know it's like, well, just get to the treatment, tell me what to do. But the treatments are, what I do, those are just the little details. It's the big picture of, can the patient handle this? What is the goal for the patient? How long can they handle it? Are they a liability risk not just to me, but to themselves? you know, and is the family all in unison? Because these are all the things that your urologist will never talk about or care about. It's not part of the equation. It's a number and not for you to die, because then that's where the lawsuits come in. But we'll talk about the MRIs, because the MRI imaging has become very popular recently. Now, in my office, we conduct color Doppler ultrasound, sort of like Dr. Duke Bond here in California. I've been doing it about 15 years now with ultrasound Doppler. And I'll just say that the ultrasound Doppler is just like the MRI. They do have their pros and cons. They each have like their yin and yang. But these images are not a means to the end. Most patients keep thinking that the image somehow is going to tell them, again, another miracle and somehow solve the case. And it doesn't. These images, for most cases, if they're not used properly, all you have is an expensive picture that shows not a low resolution risk for a cancer, but maybe a higher resolution of a risk area. And the doctor comes to the same conclusion. Well, not sure what it is. Well, so what's the answer then, doc? Biopsy. So most times imaging is used nothing but to set you up to do the biopsy that they wanted to do in the first place. But since patients now are all on Dr. Google and Nurse Wikipedia, and they all want to say, hey, well, I want to avoid the biopsy, so I want to do something, I want to avoid it. I'm going to outsmart you guys. I want to get the imaging, because the imaging is going to tell you something, I can avoid it. Remember, the biopsy is what's needed to legally go forward, and so therefore it doesn't matter what the doctor ultimately tells you. If he doesn't have that biopsy, nothing goes forward. So now, because there's so many patients coming in asking and demanding this, they're being pressured by patients on one end to get imaging, and before they would just kind of send some of you guys that were troublemakers to doctors like me or Dr. Duke Bond, right, and others. But now all of you are coming in asking this. So they're being pressured by the free market from patients saying that we want imaging, and they're being pressured by someone else. Usually the hospital administrator, because they're starting to figure out, they got these MRIs sitting around collecting dust. Well, they're not really collecting dust. They're saying, wait a minute, you got a bunch of these older guys, a lot of them have some extra disposable income because they're retired, and they're coming in wanting, with cash in hand, to use their MRI, take their money, take a picture and show them something. Come on. So that is what's happening. So these urologists are throwing their hands up and saying, fine. Now, some of them are starting to really get into this and starting to take on this new art of imaging, because it is an art in itself, but it's a tool in how you use it. But the patient's perspective is that, you know, instead of biopsying it, you just take a picture. And if you see something suspect, then I guess that means I have cancer, and well, then what? You see, you're back to that same situation. So that's why imaging is a bit dubious. And remember, I'm someone that does it. I've been doing it for 15 years. So imaging is very good. It's just, it's not used the way that patients think it's being used, okay? It's part of this amalgam assessment approach. I just wanted to give that little caveat about MRIs, because I hear about that all the time. It's funny, for 15 years we were defending that imaging was useful. The system said imaging was not useful. Now in the last 4 years, imaging is the thing, but it's, I think it's kind of causing unnecessary biopsies and maybe unfulfilled hope for some patients. Next is, we're going to talk about the prostate Venn diagram, which I think many of you are going to find probably the most useful from this talk. It's really just understanding what is it, what are these conditions, and what about this PSA that ultimately everyone's worrying about? Whether do I get a biopsy, or if you're tracking a cancer already, most doctors are following the PSA. But the PSA is quite dubious, right? Because on one hand, they say the PSA is not reliable, but then at the same time, the first thing, even those of you that don't think it's reliable, after you take salt palmetto or whatever, the first thing you do when you get your labs back is, what's my PSA? Right? Understandably, because that's the only metric that the system seems to keep coming back to. So we'll talk about the PSA. Also, newest prostate cancer specialty tests. A quick question. By the way, you guys did a great job asking those questions to get a sense of the audience, and I appreciate it. How many of you know about some of these, or have had these specialty tests, like the PCA3 test? How many of you know what that is, at least? Okay, just a handful. Okay, you know. How many have had the PCA3? Okay, how about the SelectMDx? Even fewer. Okay, so I'm going to talk about that. I think for you, so for all of you, especially if you're doing any form of active surveillance, it'll be helpful. And then 10 years survival post-radical. I'm going to talk about that now because I don't think there's a special slide for it. This is kind of cutting to the end. It's like the punchline before you get to it. Look, much of this is, when do I pull the ripcord And why? Pull the ripcord when? Well, before it's a problem. Well, how do we define problem? Well, like I said, for most guys, I just don't want to die from it. Okay, if you don't want to die from it, then what you're really, you can't die of a prostate cancer unless the cancer gets out, correct? You guys have all heard that. Now, for you technical people, that's not completely correct, okay, so the technical people. You can die of prostate cancer if it stays in the prostate under one situation, and that is if the cancer happens to be large enough and with bad luck in the location that it grows right in the middle of the prostate where it blocks the prostatic urethra. It's just a plumbing thing. If you can't pee, your kidneys back up and you have a heart attack, actually. So that's not good, right? So technically it can. Now that's not what patients think of when they're thinking of prostate cancer killing them, but that's how it could technically. So I'm just throwing that out there. But really it cannot take you out is what we're concerned about in theory unless it's metastatic. And even still, that's not always what people think at first. When people are new to this, they hear cancer and if it gets out, it kills them in 1 month. That's what they hear. Or they think about their Aunt Sally that all of a sudden had pancreatic cancer and she didn't know until the last minute and she passed away. And these are the anxieties that people have, understandably. Then they hear prostate cancer, is the one that doesn't kill you, it's weak. That's not true either. Prostate cancer is just as deadly as any other cancer. It's just that we're able to detect it so much earlier that we're finding the on-ramp, we're able to track it on the on-ramp before it's already at like at freeway speeds that most cancers are late detected at. That's why it seems as if it's weaker. Then we're going to add in the whole Gleason 6 issue, that Gleason 6 may not even be cancer to begin with, and that changes a whole lot as well. But we'll get to that later. But anyway, so let me tell you another little analogy story for those of you that might be a little anxious with it. And like I said, it's a punchline because for a lot of guys, this is really what they wanted to hear at first. They just didn't know. Now, what I'm about to tell you is not absolute and results may vary and all the little sub stuff you're supposed to put on these commercials. But here's kind of what I tell guys. Much of this is, do I have a cancer and then is it out? Okay, so fine, so if it gets out. That's what we're trying to avoid, is to have it get out. But let's say worst case scenario, it does get out. Okay, what happens then? Well, in general, if it gets out today, on average, remember this is just a generality, most men have about 5 years until they even know there's a problem. Okay, now your doctor would, because if you're being tracked, the PSA is going up and things, red blood cells can start to go down, things like that. But most patients are still bungee jumping and going to Japan and wherever they like to do. You don't even know there's a problem as the PSA is going up. After about 5 years, that's when, on average, guys start to have symptoms. The two most common, they start having arthritic pains, but then the doctor says, you're just getting old, it's arthritis, And then they start becoming tired, and the wife's thinking that, husband's acting more lazy than usual, and of course they start looking pale, and that's, of course, they're lethargic because they're becoming anemic. Why anemic? Because the cancer goes to the bone, hence the arthritis, gets into the bone marrow. It's just like a cavity getting into the tooth to eat the marrow. And then when it eats the marrow, what does bone marrow do? It makes red blood cells. And red blood cells carry the oxygen for your energy. So red blood cell levels go down and bone pain can start to occur. Okay, but that's usually 5 years later on average. Then, of course, there's treatments many of you that are on now. You have, they'll put you on hormone ablation treatment. Some people call it TIPS, obviously, removing testosterone, radiation, and there's, and there's all these new ones like Xtandi. I'm really excited about that as well. It's a neat medication. So all these medications are out there, and now you're looking at another 5 years. On top of that, now there might be some quality of life issue not having testosterone, but you're still able to move around and do things. You're not like what people think, that you're in a hospital and chemotherapy, and then the hair being lost and all these things that people think happens the next day, and it doesn't. So we're already looking at almost 10 years on average if the cancer got out today, on average. And then at that point, depending, there's a lot of variables, what the aggression of the cancer is, when it got out, where it landed, And not to mention what natural treatments you might be doing and all the new treatments that are out conventionally. I mean, if you go to the PCRI, the last 5 years, every year, there's a whole new litany of tests and options and pharmaceuticals that are all getting approved. I mean, it's hard to keep up with them. And we're looking at another 5, 10 years. I mean, these are really substantial medications. So we're looking at 10 plus years with all these variables together. And it's an important point because some men who come in at 75 go, you know, you should have told me that 2 hours ago. You know, I didn't think I'd pass Woodstock back in the 60s. You know, I'm still around. So 10 years, I didn't think about that. So I don't want to undermine it, and it's a serious issue. And I don't mean to undermine 10 years or whatever it might be. And some of you might have a different experience. But in general, it's a very important point, a tool for guys to understand when they're trying to make this decision, when to pull the ripcord, is to even understand that perspective, you know. So they don't feel as if they're under the gun as much as sometimes doctors are. Well, if you don't get this done, you'll be dead next year. I mean, I still have urologists tell guys they'll be dead in a year with a little, I mean, my grandmother had more prostate cancer in some of these cases I've seen. So anyway, all right, so the next is color Doppler trust imaging. That one, that's not for this class here, but I do, for my other doctors, I show them some imaging issues. But we already talked about how to properly use imaging. And it's not the way people think, as we talked about. All right, we're just going to zip through some of these here, examine the goals. When it comes to goals also, keep in mind that when you look at it, when I, as a doctor, look at patients, I have to look at that there's 3 different personalities I'm playing with or interacting with. I have to play like counselor sometimes. You know, there's the patient personality, which I kind of alluded to earlier, what their goals are. You know, quality of life or longevity of life. It's important. Do you want to see the grandkids get married? Is that your priority? Or do you just want to have erections till the person's 200? And I, you know, kind of like my Uncle Louis, you know? I mean, it's like, these are the 2 extremes, and most guys say, well, I vote both. Can I get both? Well, and then a lot of guys are afraid to tell me quality of life or longevity, because if they think that if they tell me, then I'm just going to turn off the other one. I see that in their eyes. You know, they start hedging. It's like this poker game sometimes in my office. And that's not what it's meant to be. It's just sometimes you have to have a leaning one way or the other, so I have a sense. And also sometimes the spouse, because sometimes the guys tell me one thing and the wife I can see looking differently over the other side. So I know there's a difference going on in the home. So all of this plays in. And then the prostate cancer itself. What is the personality of the cancer? Guys, I cannot, this is probably one of the take-home messages. I hope this group already knows this. But when people say, I got prostate cancer, and what do you think about salt palmetto, and I was going to do something. Well, it's like an alien comes down to Earth and says, well, what is the typical human being like? Or like what's the favorite ice cream of a human being? I mean, it's all over the map. Prostate cancers are, they're mutations by definition. They have different personalities. For those of you that go to the PCRI group, now, but first off, as a naturopath, I've seen this for years because I don't rip out the prostates immediately. It's sort of like, this is another Tamburri analogy. If you wake up, especially in Arizona, because everyone has guns, if you see like a gorilla in your backyard, you just shoot it. You know, you're not going to ask questions. You know, no, I wouldn't really do that. But you know, you just, it looks very violent, it's doing this, you just shoot it, right? That's what urologists do. They see a cancer, take it out. Take it, there's nothing else to do. Why wait? Now imagine you're Dr. Jane Goodall, and you're out in the safari, and you're sitting back and you're looking with binoculars and you're watching the apes for a little bit, and you start to notice, was it chimpanzees or which group did she work with? Was orangutan, chimpanzees? It may have been chimpanzees, I want to make sure I get that right, but you get the idea. She's working with the primates. And you see them, and you start realizing when they beat their chest, it doesn't necessarily mean that they're out to kill you. They might be playing, they might be, you know, mating, they could be yawning when they open their mouth up. And you start to get more relaxed, and Dr. Goodall starts getting closer and closer. Next thing you know, she's having tea parties with the primates. You know, you've seen the movie. She's doing great. She's awesome. But the thing is, she's had to learn to be comfortable, to know who the alphas and the betas and the personalities of these. If you don't understand them, then you're just scared and you just shoot them. And I've been honored, and I mean that, truly honored to be working with patients, people, you know, similar to this group, of men who trusted either me or trusted themselves or what have you, or trusted God or trusted something to not go with the system that was constantly telling them you have to do this. And their family and then the whole system pushing them like a cattle down the cattle chute to do something. And these men have stood back and drew the line, and I've been, you know, privileged to sit back and monitor them and watch them to start to learn the personalities of these cancers. And that's what's allowed me to be able to work with these patients as well, is not just the personality of the patient, but also the cancer. If my patient is a pit bull, then they can handle a pit bull cancer. But if they're a poodle, and I don't mean that in a sense the way it sounds, but let's say they saw their family members die of cancer, they saw their wife die of breast cancer, they have very low tolerance to go through that, whatever it might be, then I know they can't handle a pit bull cancer. You know, maybe a poodle cancer with basic active surveillance. So I have to play like the Yenta from Fiddler on the Roof. You know, I'm playing like the matchmaker to try to balance this out. It was a good movie, by the way. Topol, yeah, I like Topol. It's great. So, so anyway, speaking of the personalities of prostate cancer, when I graduated medical school, they had this earth-shattering result that there were 22 prostate cancers. And it was a shock, 22, oh my God. A few years later, they upped it to, I think it was 45. Stop the presses, oh my, 45, you know. Patients are coming in asking me, which one do I have? I'm gonna have number 36, you know. And then I went to the PCRI a few years later, they said there was over 100. And then, I think it was like 2 years ago, so let me go to the PCRI. 2 years ago, the main speaker, they were asked again how many cancers this year. And they said, well, there was over a couple hundred. And I think he said, you know, they said you have to turn off the camera. He's off the camera for a second. And not you, but he said, you know what? The researchers looking ahead, they're already really looking at over 1,000 prostate cancers, and they're having a discussion whether they should stop counting. Right? So, I mean, this is what you're looking at. So when patients think there's a one-size-fits-all, what herb should I take for X, or what surgery should I do? This is what I mean. These things are different. They have different personalities. And recognizing that is the first part to this. And then the patient. And then the personality of your physician. You know? I don't have much of a personality. I'm kind of low-key. But, you know, but doctors, you know, are they establishment doctors? Do they have opinions? Are they going to walk the plank with you? Or are they worried about, you know, the attorneys? Are they working for the man, or are they working for you? It's one of the reasons I don't take insurance, because, you know, I work for the patient, not the system, and I will get off that soapbox, but, you know, that's kind of what you see the problem, a lot of it is. You know, the patients don't answer to you, it's just whoever signed the check, it's usually not the patient. And you know, that, by the way, I didn't get in my background, I'm not getting much into it, but I have a business background. I'm an Austrian schooler, and used to, back in, you know, neoclassical Austrian versus neo-Keynesianism and whatever. But business, a lot of my men, I've learned, who come see me have a business background, they're CEOs, what have you, and that's another part about the physician personality. You guys have to understand, you know, you guys are older than most of the doctors who you're seeing, right? I mean, you guys grew up with Marcus Welby, and they don't know who Marcus Welby is, and you're like, where is Marcus Welby? This is not what I signed up for, right? And then you're sitting there. And then, you know, of course, they're a younger guy thinking that you're some old guy's not having sex, you know, and they're not going to talk about that, right? And so, and I'm not trying to be too flippant with my friends, the MD types, but, you know, they have been told how brilliant they are since they're in high school. And then they go into college, and then they go to medical school, and they have a residency, and an internship, and then they get this whole the practice bequeathed to them, and then they're part of the system. They've never signed a payroll check. Like they've never had a lemonade stand. They've just kind of, they're all book smart. But the system is half of your problem. And those of you probably know this, especially when you're older, whatever the issue is, you love the ones who've dealt with it. I tell my patients in my office, prostate cancer is half your problem. You think that's your problem. The other half is the medical system you're up against. And it's not meant to be this whole political issue that we're all dealing with right now, but it's been an ongoing problem. And if you don't understand the personality of the doctor, where are they coming from? What are the liability for them, their personality? Will they go to the mat with you? How far will they push it with you? Are they willing, or, you know, after all, they don't want to lose their practice and livelihood just to save your erection. I mean, that's really what this comes down to. You want them to push it as far as they can to the edge, because you don't want quality of life issues. But they can't be sued over quality of life. They get sued if you die. And so there's a conflict of what the goals are. That's why I always come back to, what are the goals? What are you trying to do? Okay? All right. So that's what I mean by referring to the patient perspective and the physician's perspective. All right, some comfortable truths. We're going to see how many of these we can go through. And I'll certainly also want to go over some of the highlights too, are some of these specialty tests, and most of you don't know what they are. And also some active surveillance guidelines, ultimately, of when to pull the ripcord that I recommend to doctors and to groups like yourselves who are more actively tracking or taking care of your own health. All right, so what is your goal we talked about? Do we all have cancer? Well, technically we do, right? So we have to redefine it. What is aggression? We discussed that. Oh, and by the way, I mentioned about the NDNR articles each year. The last 2 years were sort of like a 1-2 combination series. The one from 2017, it's you can download this for free online, ndnr.com, put in my name. It says prostate cancer discussion, just what is aggression? And the entire article is really dealing with that question. What is aggression when we're talking about it? Obviously Gleason technically, but then how else can we define it? So for time reasons, you might want to check that out. When are we cured? This is an important one. When do we stop treatments? I mean, people say, yeah, stop yapping, just tell me what to do, I'm anxious. Okay, fine. I can turn into some standard alternative guy, sell you a bunch of overpriced supplements, make you feel good like you're doing something right away. And then I just sit back and watch, 6 months later, a year later, 2 years later, eventually patients either don't come back because they just stopped taking it and someone else offered them some elixir and they move on, or they come back and they say, I'm spending a lot of money on this stuff and so when does this stop? Because I'm looking at my taxes and it's, I'm on fixed income now and everyone's telling me to take more stuff. And like, what exactly is the goal here? And it's sort of like, it's like, again, the Congress, they'll pass a new law for a tax that's a temporary tax, but they never say when they're going to repeal it. You know how that is? It just ratchets one direction. And that's what often happens. You're just put on supplement, it ratchets up, but you never seem to have a goal, the exit. Those of you who play the stock market, no, you don't play the stocks unless you know your entrance and you know your exit point. You need the exit. If you don't know the exit point, you just keep watching it go up. Well, then, that's when people get burnt. So you need to know your exit. What is the goal? And I can't stress that enough. You need to write them down. Sometimes write down columns. What are my goals? And have your wife do it as well and put them together and see if they link up. Okay? When is it gone? Like I said, how do you say that cancer is gone? After all, if we have cancer in us all the time, well, how do you really know it's gone? This is a very important question, because when people are spending all their money and time saying, I want a cure, I want to take, okay, well, what's the goal? What do you mean what the goal is, Dr. Tamburri? I just want the cancer gone. All right, well, let's think about this. When is the cancer gone? Is it when the PSA goes under 4? Does that mean it's gone? I'm sure this group already knows that's not true, just because it's under 4. So then maybe a patient says, well, if Dr. Tamburri, if you said that the legal diagnosis is on a biopsy, then after I do my IVs and change my diet and everything else, well then if I got another biopsy and the second biopsy comes back negative, which is technically really, they say undetectable, not necessarily negative, but let's say it comes back undetectable, I'm cured? I mean, do you think the nurses and the urologists are going to come with a ticker tape parade and go, ooh, tell me what herbs you were taking. I can't believe this, it's gone. No. They're going to say that they missed it. And let's do it next year. Because they had it the first time. Remember, legally, they have that biopsy, which, by the way, if you don't know this, is in a freezer at your hospital for about 7 years. It depends on your state. It's called the statute of limitations. And so you don't realize, but your cells are staying in that freezer until it runs out. They're running the clock out. So this is the system in the game. So ultimately, it's when is it gone? So like I said, sometimes we have to change what our goal is. Not to have the cancer gone. Maybe it's to have a level that you're willing to live with and it not to get worse. So maybe the goal is, what is the rate of increase, or hopefully it doesn't increase, whatever markers we're using, and then find out what your life expectancy is, and are you probably going to pass from something else rather than the cancer itself. Okay? And then, all right. So one of the most important things is knowing why the PSA is elevated. That's one of the main goals. And the second goal, I can't read here, says not passing or passing from prostate cancer and balancing that with quality of life, essentially. All right, this is the chart I really wanted to show you. I actually created this very quickly just when I was giving one of my speeches to doctors, and it just came out. This is what's in my head all the time, and it was easy for me to put out there, and my patients seem to really appreciate it. So I even have a little flow chart I have in my office now, or a little one sheet here I made. So This is pretty much my brain. You know, this is the only thing I have in my brain, these three things. If I see a woman in my office, I'm clueless. I don't know. But this I know, and I know them very well, okay? All three of these involve the PSA. Now, why is this important? Because when most guys come in, I'll give you an example. They say, do I have prostate cancer? Or tell me about the prostate cancer. I say, okay, well, why are you asking that? Well, because my PSA is high. I said, okay, well, if your PSA is high, it means you have prostate cancer, right? Or it's worse. And they say, yeah, but Dr. Tamburri, don't you know, I heard that PSAs are not reliable. Yeah, I thought you knew that. Yeah, no, I know that. But if you're worrying you have prostate cancer because your PSA is high, then I guess you have it. But if you're telling me you don't trust the PSA, then your question is not, do I have prostate cancer, since we have it all the time anyway. Your real question is, why is my PSA high? Remember the motorcycle case? Okay, he had cancer, but the PSA went up. It had nothing to do with the cancer. You guys with me? So this is why understanding what is your question. Is the question, do I have cancer? Just go get a biopsy, and they'll tell you if you have it officially. Or maybe the PSA issue. It seems obvious at first, but it's hard sometimes to wrap your head around it. It's a different way of looking at it, okay? So once I get the patient to understand it, that's what we're trying to focus on, even if you're already diagnosed with cancer. Because if those of you would say, well, I already know I have cancer, yeah, but your question really is going to be, well, all the treatments I'm doing, are they working? Well, if we're back to PSA, then we're back to this again, all right? So what if you have cancer and you have BPH, which all of you guys do to some degree, and then you just throw prostatitis, which is the #1 reason that PSAs go up under 15, right? You got all three. So if the PSA goes down, what got better? Did the cancer get better? Did the BPH get better? The prostatitis? Saul palmetto is used for a lot of these anyway, right? So what is it? It's sort of like, this is the analogy I give also. I talk about a lot of crazy analogies in my office. So the polar bear is the cancer. If the polar bear is in a desert in Arizona, you can pick them out. It's pretty easy, a polar bear in the desert, right? That's the cancer. You know, PSA goes up, cancer worsened. PSA goes down, cancer improved, right? That's what people think this is. But in reality, the prostate, you've got a polar bear, but he's on an iceberg, a white iceberg, right? Hopefully you guys know this about BPH, right? BPH, for the record, does not mean big prostate, but it's a hyperplasia. I won't go into that right now, but in layman's terms, okay, there's more cells. That's what a hyperplasia is. Most of them get larger, many of them get dense, but just to give you a sense here, sorry. So you have 20, 30, 40, 20, 30, 40. These are early stage prostates. 30 to 40 is beginning BPH, okay? 40, 50, 60, that's about moderate size BPH. And the reason that number 60 is very important is because 60 is the limit that natural treatments stop working if it gets over 60. So for some of you that take Saul palmetto as an example and it works, you could have a normal sized prostate. If you have Prostzilla and you have 120, you know, I've seen up to 527, by the way, in my office, and he has no symptoms. The larger prostates usually don't even give you symptoms, which is contradictory to what my guys think. That's another story. But the thing is, you can have a large prostate. Well, why is this important? Because the larger prostate means that you have more cells. And if you have more cells, then each cell is normally making its daily amount of PSA. Remember, PSA is not a cancer marker. It's a marker for prostate-specific antigen. So anything that affects the prostate makes that thing go up. So if you have a larger prostate and more cells, you have a higher PSA. Makes sense. So therefore, if your PSA is 7, well, if you have, you know, a small prostate, a 7's bad. If you have a giant prostate, I'm wondering why your PSA is not higher. And you might say, well, that makes too much sense. How come my doctor didn't do that? Well, the reason is because the only way, now it's a little changing a little bit now, but the only way you find that out is doing an image. But they won't do an image, at least traditionally, without the biopsy, right? Because they don't want to spend the time and the money setting you up, having, you know, I mean, yeah, it's a process. Anything a hospital or a doctor does, it's a process, you know, with all the people involved. And not to be too funny with it, but, you know, then they have to hire a nurse because, you know, doctors don't want to be accused of sexual molestation in their office. You have to hire a witness to be in the office, literally. So now you have to pay somebody, and it just becomes an issue. It becomes an issue in order to do it. So without that biopsy, they don't want to go forward. Does that make sense? So anyway, so BPH and knowing the size of the gland is important because the larger it is, the more PSA. So now we have a cancer of some amount putting out PSA on a large prostate of some kind that's also putting out PSA. That's the large iceberg that the polar bear is on. But wait, there's more. Now we have a blizzard, right? That's the inflammation, which is the #1 reason that PSAs tend to spike up and down. So a white polar bear on a white iceberg and a white blizzard, and the patient keeps asking me, what about the polar bear, right? So that's why it's always important to get down not just what the cancer is, but what else is involved, to what degrees, because ultimately that's what everyone's going to be looking at to monitor to go forward, okay? And I find that sometimes in the very beginning with patients, they get a little frustrated first because they come in talking about prostate cancer, and I'm talking about prostatitis and BPH and asking all these other questions. They don't think it's relevant. Or sometimes patients come in about BPH and they wonder why I'm talking about cancer. It's because they're all they're all intertwined. Okay. Now, these have something in common. These are all linked. Well, by the way, I think this group already knows this, but I always put these little caveats, little Barry Bonds asterisk at the top here. Prostate cancer, you know, most of you guys know most men don't die from it. There's like a 1 out of 40 chance that men typically can die of prostate cancer, and it depends what study that you read. BPH, I already just said, it does not technically mean a large prostate. It's a hyperplasia, which does play into sometimes the analysis. And prostatitis, this is key. Prostatitis does not mean an infection. It does not mean a prostate infection. It could be, but it's only about 10% of the time. Prostatitis, anytime, guys, this is like a medical thing, anytime you read itis, always means inflammation. So tonsillitis, pancreatitis, you name your itis, it means it's an inflammation. Now, infection can cause an inflammation, and depends on whatever that you might be, that you're looking at, but most times when it comes to prostate, only 10% of the time it's an infection. 90% of the time, it's the motorcycle, it's sex, too much sex, not enough sex, rectal intercourse, anything from 50 Shades of Grey. I'm getting that a lot. You've got things like from traveling to Japan, if you're a private pilot, because the altitude or the lack of a pressurized cabin can make the prostate swell up. Being an international, do a lot of international flying, like pilots, sitting on that prostate as a pilot or a motorcycle rider. Right? Truck drivers, I mean, keep going on and on. You know, weightlifters, I mean, if you're doing like what do you call it, a military press standing, that's excellent. Military press sitting, that's the worst thing you can do because all of that weight is going right down into that prostate. So guys sometimes do things they don't even think about that add into it. You know, heavy machinery, people use jackhammers or sanding or John Deere lawnmowers and tractor equipment. Whether it's their profession or a hobby. I mean, many of these things play in. Quads, snowmobiles, speedboats, things that bounce, you know, and sometimes a combination of these together. Autoimmune disease, if you have an autoimmune disease, a lot of you guys are older, you don't even know you have it, maybe a subtle autoimmune disease that's never been diagnosed. Well, when your body gets inflamed, your prostate's part of your body, your prostate gets inflamed. And by definition, that's a prostatitis. So if you're an uncontrolled diabetic and your sugar level goes up, well, you know, sugar in your blood that's not being tracked or regged by your system is inflammatory. That's why diabetics go through all these problems, right? Your body gets inflamed. Hence, one of the tests that we run with the PSA is the C-reactive protein, which is an inflammation marker. Because if your inflammation marker is up at the same time your PSA goes up, I don't trust the PSA. So that's why prostatitis is very key to understand, because this is like the icing on the cake that affects everything else. All right, so let's go on to the next one. They all, as a Venn diagram, they interplay. So let's talk about these. This I think will ring some bells for a lot of you. So what does prostate cancer and BPH have in common? Is that they're both hormonal. That's what they do. As a matter of fact, you know, I think for many of you know this. You know, if you want to slow down a prostate cancer, what do? Technically, right? Remove the testosterone, whether it's a Lupron shot or an orchidectomy, what have you, right? Slows it down. You want to shrink a prostate, what do? Remove testosterone. A little bit less, but they give you drugs like Proscar, Avodart, All right, that's what they do. They block the conversion of testosterone into free testosterone and the active form of testosterone, or DHT, I'm sorry, testosterone. Yeah, my little tongue-tied this morning. I apologize, I'm a little dry here. So anyway, but BPH and prostate cancer, they're both hormonal. Interestingly, what is the most famous herb that lowers testosterone levels? Saw palmetto. I kind of pick on it. I shouldn't pick on it as much as I tend to, but it's like the cliche. It's like echinacea. Everyone's like echinacea and kava and saw palmetto. It's an oldie but goodie. It just depends on how you use it. The problem is I have many guys that have prostate issues. They go to the health food store and they sell them saw palmetto, but they have prostatitis. Prostatitis has nothing to do with hormonal. You're wasting your money with saw palmetto if what you're really dealing with is a prostatitis. It has nothing to do with it. So that's why I always come back to what are we treating? You know, what is the underlying issue that's making your PSA go up? Okay, what does prostate cancer and prostatitis have in common? Well, it says right there, inflammation, right? Because all those things I told you, urinary tract infections and motorcycles and everything can make it inflamed. Autoimmune disease, but guess what else can inflame the prostate? Fighting cancer. So cancer causes inflammation as well, which is why anytime that you hear about cancer treatments naturally, breast cancer, what have you, they're slamming you with anti-inflammatories and antioxidants to deal with the damage of the inflammation. Now, you know, I'm just talking in general terms here, but the best ways to reduce inflammation, just the general, you know, the big guns would be fish oil or EFAs, strong EFAs, of course, you know, making sure they're molecularly and pharmaceutically distilled, really high concentrated fish oils, and certain botanicals, curcumin, or a liposomal form of curcumin, not just any curcumin, a liposomal form. They've been around for the last 6-7 years now. Those are highly absorbed, and that's why most cancer clinics, MD Anderson and all, even those that are playing with natural medicine, they tend to go to those too because there's so much evidence-based behind it, and you know they have to feel protected with the evidence-based, and I'm not trying to be too flippant by saying that either. Okay, so that's why the inflammation is important to figure that out. How much of inflammation is here or here, but it plays into it. So, for instance, to give you a sense now of when, if you're trying to figure out the PSA, the first thing you want to do, right, you're trying to find the polar bear on the iceberg in a blizzard, and you're trying to figure out where to find that polar bear. What's the first thing you want to do? You want to wait for the blizzard to go away. So at least you have a clear shot, right? And sorry I keep using this Arizona example here, but it's just, I have to find another analogy. But the point is you have to wait for the storm to go away. So you have to identify the prostatitis, treat it, or at least, you know, hopefully treat it. And then when you do, the PSA hopefully comes down, and now the residual PSA is between these two. You see? Then what you do is you find out the size of the prostate, calculate what the density is, and that tells you what the excess PSA would be for that size prostate. So now you've adjusted for prostatitis, the size of the gland, and now what's left over, in theory, is the PSA left over for the prostate itself and any cancer that might be there. So if you're still left with a high PSA after that, then maybe you're looking at cancer. Does that make sense, guys? So it's rational deduction of what is going on, which is why it's not about, do I got cancer, what the biopsy says, it's all of this together. All right. And then there's one last one on the board, and I didn't forget it, trust me, it's the most important. And that is, do you have urinary symptoms? Okay? This, hopefully all of you have seen one of these. If urologists did halfway their job right, some of these guys don't even use. This is the international symptom score that every urologist in the, at least generally uses, supposedly. Now, they don't do this often because they're always asking about you. They have to put this as a record because if they're going to charge the insurance company for your treatments, they have to prove that there's been gain from the treatment, so before and after. So here's what the symptoms were before we saw them and gave them drugs, and this is the symptom after. So you can justify reimbursement. That's what a lot of these are, and that's why they're standardized. But I love it because I want to know what patients are thinking. And men tend to be, you know, not as much qualitative, but they're good with numbers to say, okay, you know, 1 to 5 and position it in. So these are questions, you know, do you have urgency and incomplete voiding and frequency and nocturia, and I'm sure a lot of you guys have dealt with this and you understand what these are, but here's the point though. The point is, I always give that form to my patients when they walk in, and I usually save it for last because I don't want to, I'm like not showing all my cards immediately. I want to get a sense of where the patient's coming from first. But then I look at that. Once I get all this out of the way and I explain it to them, then I look at the symptoms. I tell my medical students, I love men with peeing problems. I love it. I love it. And my students, they laugh. And they say, of course, Dr. Tamburri, because you love urine and it's good for business. And I say, yeah, well, that's not really the reason. Well, maybe. No, the real reason is I love it when they have peeing problems, because if they do, it means it's probably not prostate cancer. Right? It means that I know that one of these or both of them are involved. It doesn't mean there's not a cancer there. But remember, is the question, do I have cancer? Is the question, why is the PSA high? And if the PSA going up as it drives in my office, I need to figure all this out. If they have symptoms, I know I'm dealing with one of these. Now, look, guys, sometimes you can have symptoms, especially if your cancer is really big. But by the time a cancer gets large enough to block the urethra, which I taught you earlier, the PSA, usually it's a large enough cancer, the PSA is, 20, 50, it's higher, and usually I'm not even seeing them at that level. I already know it's cancer. But a PSA of 8 or 10 or 5 or whatever it is, it's usually not cancer, right? So when guys sit there and I ask them about their symptoms and they say, oh, I don't have any symptoms. So then I say, okay, if you jump in a DeLorean and go back 2 years, did you have any, did it change? Was it different back then? And they say, doctor, I keep telling you, I'm fine. And then sometimes they get all frustrated and they say, hey, look, I take these supplements and I jog every day and I run the Ironman and I can write my name in the snow and all of this. I am fine with urination. I'm fine. Let's move on. And I say, okay, you done impressing me? Now that you just told me all that, that means I'm looking at cancer. Because, right? Because the reason I don't say this at first, guys, because again, there's a give and take, is because if I tell them I'm looking for symptoms immediately, then they start telling me about, oh, well, you know what? I think I woke up, 10 months ago and I had to pee after a coffee, and then it throws it off. So that's why I usually wait till later. All right, I don't have a little more time left. Did biopsy or not biopsy? The 10-year survival, we talked about that. The personalities. And these are my two little other friends. I have a 2-year-old now, but these are Cappy and Mimi, and they're black and white, and just like these cancers, they have different when you see a baby picture or a cat picture, I'm like some dude, they all look alike to me, whatever. But now that I have a 2-year-old, or cats, you see that they have different personalities. All of you know this, once you get to know these beings, pets or children, strong personalities, and I can't stress enough, cancers do as well. All right, so I don't have time to get into this right now, but these are just considerations of just thinking of how myself, with the years I've been doing this, I look at PSAs differently. As an example, I'm gonna do this really quick, so you may not get all this immediately, but like, which is worse, a PSA that goes up 2 points, 6 points, or 10 points in, let's say, 3 months? Most people say 10 points, that sounds bad. And the urologist is definitely going to hog-tie you for a biopsy. But the thing is, 2 points worries me more than 10. Because there's no way a cancer is going to go up 10 points in 1 month. A cancer can't grow that quick. So if it goes that quick, it's like the stocks. The faster they go up, the more they're going to crash. It's like the dead cat bounce for some of you stock people. That's what it is. So when it spikes that high, I know it's not cancer. Doesn't mean cancer is not there, but that's not the spike. So that's why the velocity is very important. What else? Which is worse, a T3 Gleason 6 or T1 Gleason 10? In other words, I'll give you an example here. So which is worse, having a Gleason 6 low aggression cancer at the edge of a small prostate, or a Gleason 10 in the middle of a big prostate, right? Which is more aggressive? Now, since you guys are passing my class today, every one of you should have the answer. Which is more aggressive? The second one. That's a Gleason 10. Period. End of story. That's what aggression means, is Gleason. So Gleason 10 is more aggressive. You can't get from that. But if you're going to change your question and say which one has more of a chance of killing me, which one can get out of the prostate easier, the Gleason 6. Because it's already at the edge of the gland. And remember, cancer can't kill you if it stays in the prostate, only if it gets out. So the closer the edge it is, the higher risk it can get out. And if that's the question, then that's why that word aggression, guys, is so important to understand what it is and what it's not. Okay? Next, which is worse? 1 out of 12 cores Gleason 6, 12 out of 12 cores Gleason 10. The first Gleason 10 I saw was a guy, he was a George C. Scott and Patton, that was my patient. God bless him. He came in, he was smoking Camel cigarettes in my office, and my front desk flipped out. I loved him. I just said, look, the last time this dude saw a doctor, the doctors were smoking in hospitals. That's how long he stayed away, right? So he comes in, and he was a vet. He had all the Semper Fi, and the guy was like 85, whatever, and he talked about he lied about his age to be in World War II, and he worked with MacArthur. I mean, and he was using like colorful metaphors that they use in the military, and I loved them. But here's the thing, though. He had 12 out of 12 cores Gleason 10. I'd never seen it. I felt his prostate. I thought my finger was going to cut off. I couldn't believe it. Oh my God, it was a whole rock of cancer. It was like the worst you see on here. It's like Carl Malden's nose. That's what it felt like. Anyway, that's what it was. But the thing is, I'm sitting there, I've got this cancer, and I went, oh my God, I was a younger doctor, and I was myself like, my God, is this a liability risk? And I asked him, well, what happened when your doctor told you about this cancer? He said, oh, he told me I had, I think I have 9 months to live. And that was 6 years before he saw me. And remember, he's smoking Camel cigarettes. So it's not like, should I have reverse osmosis water or this water? He's smoking Camels. And of course, he was a guinea pig for the U.S. government, at Agent Orange and the Bikini Island experiments and all the rest, right? That's where you get these, by the way. And if you vets out there, I don't mind talking with you even extra because, to support you guys, because VA doesn't often, God bless them too. But anyway, it's a problem. But in the 12 out of 12, so here's the kicker. I mean, the Gleason, first off, doesn't always mean it's going to get you. What I've learned is that the Gleason, and from the very beginning, thank you, it's the division rate. See, extra points again. It's a division rate technically, but it doesn't mean it's going to get out. They have different personalities. The irony is the ones that divide quick often, and this is not absolute, all right, no absolute, but how does it get to take over the entire gland, the entire thing, and not get out? It's because the personality of these things, they can divide quick, but they're homebodies. They get to the edge of the gland. It's like a French mime, and they do this thing, and they work their way around the inside of the prostate, and they don't get out. I mean, I'm not saying they don't. I want to be really clear, especially taping me. I don't mind. I mean, I don't care, but it just don't be clear. I'm not saying don't worry about it. But if I see a Gleason 6 or any Gleason, whatever it is, a new diagnosis at the edge, or it's random, we don't know where it's been, where it's going. It could get out, it may not. There's a lot of factors that, we don't have the time to go into all of them for today. But if I see the entire prostate filled with cancer, guys, that didn't just happen 2 years ago or 6 weeks ago because you ate a Twinkie by accident. That's not where it comes from. That is something that's been there for decades in order to grow, to get to every nook and cranny of this gland. And if it hasn't gotten out now, why is it now a problem? Because the doctor finally found it? Christopher Columbus finally comes to America and he discovered it? It's like all of a sudden, well, God, you have a cancer. Well, it's been there for 20 years. Well, what is it that we're looking at? So anyway, I get a little animated about that, but it's just something to just be aware. I'm not trying to downplay Gleason's, I want to be clear, but I wouldn't have said this 10 years ago. It's only by doing this practice long enough, seeing enough patients, that you start to go, well, wait a minute, what am I really tracking here? What is the issue? If the issue is not do I have cancer, but is it going to get out, and the entire thing is full of cancer, and the person's how old, and what's his life expectancy from his family, and this and that, and is this cancer putting out PSA, and if it's not, well then, how is it active? Is it moving at all? I mean, there's so many factors that go into it. But, the urologist, all they see is this, and they just say, oh my God, lawsuit, and they rip it out. So, I'm going to end on this point here. When to pull the ripcord, which is kind of the very end here, so I have to finish up. Normally, what you're being told is that the PSA is over 4, and if they find anything on an image, biopsy or remove it, and if they find confirmation of cancer, that's when they say either rip it out or your regular doctor refers you to the urologist, and then he's going to do that. The level 2, and this is normally what I give to physicians that I'm teaching, so they have an understanding how the different levels of risk that the doctor's willing to take, and the personality of the patient, how much risk are they willing to take. But level 2 would be doctors that are trying to be more integrative with this and push it a bit. Is the PSA over 10? PSAs 10 and under are now considered no man's land. It doesn't mean that it's cancer if it's between 2 and 10. It just means we need more information to figure out what it is, whether cancer is there or not. So the old standard was under 4 and over 4 was bad. Now it's under 2 is green, the green zone, 2 to 10 is the yellow zone, and 10 and higher, now most urologists consider the red zone, okay? Whether they tell you that or not. The percent free, and I think you guys know a lot of these are, the percent free should be under 10%. If it's under 10%, then that would be more of a risk. If the velocity, if your PSA goes up a point per year for 2 to 3 consecutive years, then they get nervous about it. Strong family history of prostate cancer, carcinogen history, DDT, 2,4-D, Agent Orange. If you have more than 3 cores positive on the biopsy, then you're not a candidate for active surveillance by standard urologists. If any of the cores are over 30% of any of the cores, even if you just have 1 core Gleason 6, if it's 31% of the core, technically a lot of doctors won't work with you with active surveillance. And if any of the biopsies are a high 7, so a 4+3 or higher. It depends on the doctor. Some doctors don't like any 7s, but, and if they found HG pin cells or perineural invasion, any of those, they will say that you are not a candidate. So the last thing, since this is level 2, in my office, or ultimately when to pull the ripcord, to me, is this is pushing the envelope. I'm just acknowledging it, but this is what we're looking at, is the PSA density, which is this thing here, the PSA divided by your volume, and you don't have to worry about the numbers, you can take a picture. But basically, if it's in the acceptable range, 0 to 0.15, that's the green zone. Yellow zone you can see, and the red zone is density. Prostatic acid phosphatase. Every one of you guys should be testing this one. It's a regular blood test. We can talk about it in Q&A if you want to know more about it. But same thing, are you in the green, yellow, red? And this is the old PSA test. This test normally only goes up when a cancer's gotten out of the prostate or it's about to get out of the prostate. That's why it's a great canary in the cage, in the coal mine. And then the T status, which I referred to, is the cancer in the middle of the prostate? Is it at the edge, or is it bulging out? Green zone in the middle, yellow zone at the edge, red zone if it's bulging out. So to finish all this up, those are I give you 3 canaries, not just 1 canary because I'm nice. I give you 3 canaries. So you're going to that coal mine. How far do you want to go for quality of life? The gold at the end of the coal mine. If you want longevity of life, don't go into the coal mine. Just rip it out. Okay? Don't even go with it. But if you want to go all the way for the gold, you know, if you're an Austrian schooler, they'll go for the gold, well then you might wait until 2 of these go red zone and the 3rd one's yellow before you pull the ripcord. Many of you guys might say, well, I'll go in until the first canary starts to cough, then I'll turn back. You see my point? So to summarize, this is what I mean by when to pull the ripcord. It's a combination of what your goals are, what your risk tolerance is, also the doctor, and also what all these other numbers are, what the physician's role is, to piece them all together to say, okay, how much risk do we want to work together? If this is the cutoff, where are you now? Where's the cutoff of point of no return? How quickly are you getting there? And how far close to the edge can we get before you decide, you know what, maybe it's time to turn around or pull the ripcord. So there's more to it, but hopefully this gives you an overview of generally what this is. And my last article on NDNR, which Bill, I think, may have posted somewhere, I'm not sure, but it's from 2018. It's on when to pull the ripcord. So it's the follow-up to the aggression article. And hopefully that will summarize much of whatever I didn't get to today. So thank you for your time, and I guess we'll have some Q&A.
Can you say something about, there was discussion about whether Gleason 3+3, 6 is cancer?
Yes, yes. So,
in particular, like if cancer tends to be fast growing, I'm saying, and you can track it with various ways in the body, then you can find it with certain tests. Will those tests not show up Gleason 6?
yes. Yes, they show Gleason 6. Yeah, so the question is about, when I commented earlier, did you need, the question was what I was alluding to earlier about Gleason 6 being cancer, and of course also I think what you're mentioning is that there's tests out there that can show progression of these tests, so what does that mean? Let me comment on that Gleason 6 issue, because this is probably one of the most important things to talk about now for those of you that are new to this. This is something that doctors are not making mainstream. They're having their own little private talks on this. And that is Gleason 6 cancer even a cancer? Now, they're not trying to bring this up and make this too public because it's sort of like when smoking companies admit that, tobacco use causes, cancer, and or, amalgam fillings mercury can cause a problem, then all of a sudden all the lawsuits hit. So they kind of don't want to bring it up right away, but they're wondering, is it really cancer? Why? Because Gleason 6, it's markedly different when you study it from other cancers. Also, it images different. For those of you, of course, with ultrasound, it looks different. Many times I have to prepare patients. You may not often see Gleason 6 on an image. Patients wanted me to show them like where it is, and cancers don't always show up like that, especially Gleason 6, and most guys are diagnosed with Gleason 6. Those of you who have had MRIs, they're rating it by what's called the PIRADS. You guys all seen the PIRADS? Right? So a low PIRADS is maybe more hypo or less hypoechoic, meaning that it's lower intensity, whereas 7s, 8s, and 9s and 10s are higher, right? So we know there's something different. Not to mention, when most men don't die of prostate cancer, it tended to be Gleason 6, but some men did. Here is what has changed recently, because it was based off of the imaging findings that it looks different as more doctors are starting to figure this out, and something else that's very important. There's been an ongoing question of the universe in prostate, which is, can a prostate cancer upgrade itself? Can it transmutate? So can a Gleason 7 turn into an 8, an 8 to a 9? Can that happen? The answer is we didn't know. The leading thinking, and I have to say I agreed with it, which was that it did not. Because in the Petri dish, a Gleason 6 divides and it's a clone of itself. So 6 is a 6 and an 8 is an 8. That's what it is. So we just assumed that would be the case until proven otherwise. Well, it looks like it's true that they do, that they can. And it's a lot of research trying to come to that conclusion. It makes sense, exactly, but in order to, we couldn't see that. So let's change the game, because now the people who think that Gleason 6 could never kill you were always hit with that argument of, yeah, well, these men were diagnosed with Gleason 6, and 10 years later they died of prostate cancer. But now the thinking is that they were diagnosed with 6, but maybe 7s or 8s were there they didn't find, or the 6s turned into a 7, and 10 years later that's what got out. Now a patient might say it means the same thing, but it's a big difference if we're looking at how problem that Gleason 6 is. So is it a cancer or not? Not to be funny, but I try to tell my patients it's like the planet Pluto. All of us, it was a planet, right? 9 planets, and it's a planet. And then Neil deGrasse Tyson gets out there and he says it's not a planet because it's got an odd orbit, and I don't want to get too geeky, but it's not a planet. Demoted, some more textbooks to schools. All right, so all that. And then the New Horizons probe goes by, and they go just a few years ago, and they find out that Pluto is a remarkable planet or something. It's got an atmosphere, it has geological formation, all this sort of thing. So is it a planet? Is it not a planet? Pluto is just doing what it's doing. It's just our limitations of trying to put it into a box. That is what Gleason 6 is now becoming. Is it a cancer or not a cancer? And for all the liability and overtones on top of it, what is it? How do we treat it? Should we treat it? Should we call it a cancer? Right now, to finish up that Gleason, what the doctors are saying kind of off the record is, well, let's just keep amongst ourselves. And I'm telling you guys with the respect of the information, don't be running around saying, oh, it's not a cancer. I'm just preparing you that maybe in 5 years from now, it'll become common knowledge and you start to hear that it's not. The problem that I have, though, is knowing this and already kind of hinting this for a while. What do I do when I have a gentleman the other day who's only 45 years old, diagnosed with Gleason 6 cancer? Every doctor wants to rip that out because he's a young guy. But can I imagine in 5 years, Dr. Oz says, guess what, it's not a cancer now? And that gentleman, maybe he doesn't have erections the rest of his life, and to find out that it wasn't a cancer. I mean, and knowing that, it's put a huge spin on how I approach things. And I'm still trying to work that out. So I appreciate the question. I wanted to just give you, respect you guys, that information is kind of in smoke-filled rooms right now, and I think, just work with it the best you can. Anyway, thanks. Another question?
Okay, question here.
Yes. The question is, I think several of the people here have gone beyond this chain of diagnostics. They have had a radical prostatectomy, and the question at that stage is, as a quote, cancer survivor, you go back and you monitor your PSA. And the PSA starts rising, then they give you a testosterone inhibitor. My question is, are they chasing something that isn't there? Because the premise of these procedures is that you still have cancer, it has escaped, it's someplace, you cannot find it. You know, they give you an MRI, they scan you, and they can't find anything of significant size any place, but they still follow that protocol. Commentary?
Just they're tied. I mean, if there's the PSA, then they fixate on the PSA. The only thing I'd point out is if you still have a prostate, then PSA can be a cancer linked. But if the prostate is gone or decimated, then in theory, any PSA that goes up is now what they would say pathognomonic linked to cancer. And it's sometimes guys have like whiplash dealing with this because they spend so much time, you know, distrusting the PSA and kind of doing this, do I trust it or not, and read all this stuff. But the minute the prostate's technically gone, then it is more black or white. If the PSA goes up and you don't have a prostate, it's coming from prostate cells somewhere. So therefore, and that's why they use that as the modus operandi to keep going. Yes?
All right, yeah, a question back there.
You're the boss.
Back there, you had your hand up.
Yeah, I did. I'm wondering how the drug finasteride plays into knowing what your real PSA is, or for that matter, your PSA density. It's kind of hard to figure these things out when you take finasteride. Is there a standard rule of thumb that?
Yeah, well, there is. The rule of thumb in my office is not to take it if you don't have to. And that's another issue, is do you really need it or not? Because many people with BPH, they don't have the large prostate, or even if they do, they don't have any symptoms. So if you don't have any symptoms, then why do you want to shrink the prostate? When you tell a guy they have a large prostate, they go, oh, well, it's big, I want to shrink it. Tell me something to shrink it. Well, shrinking it may not be really what you want to do. You don't need to do it because there's a lot of side effects to shrink it. Most men who have BPH and urinary retention, they tend to have a dense form of BPH. That is why, by the way, guys, just like there's 1,000 different prostate cancers, there's 2 basic types of BPH. In my office, or my students, I call it Manhattan BPH and Mesa, Arizona BPH. Mesa. All right? Why? Because if you double the population of your city, what happens to the city? If you're in Mesa, land's cheap. You knock some cactus and you build out. You get city sprawl, but low density. With low density, that's why without density, there's no pressure on the urethra causing the problems. Whereas if you're in Manhattan and you're landlocked, you're dense, you're locked, you build up. You get the Twin Towers. I mean, there's even, for those of you after class here, where's my prostates? Anyway, I lost my hair there. You come up afterwards, but these two here, these are 2 examples. This is a Mesa one, it's flat and large. And this one below is tighter and has these 2 lobes, like the Twin Towers. And the two skyscrapers pushing on the urethra underneath give you more symptoms. So the irony is many people who have symptoms actually have a dense form of prostate, not a large prostate, whether they have it or not. And to cap off somewhat that question, that's why there's 2 classes of BPH drugs. There's only 2. There's 5-alpha reductase inhibitors, which that's with dutasteride and finasteride, Proscar and Avodart. They shrink the prostate. But then every other drug you've heard of for BPH that Bob Dole's on, all of them are alpha-1 blockers. They don't shrink the prostate. They relax the prostate. And that's what you want to do. If you have a dense Manhattan form, you want to relax it. So that's why there's 2 different classes of drugs. Flomax and the alpha-1 blockers, those have very low side effect profile. They're cheaper. They work in a couple days. And they have, and if you stop taking them, everything comes back. And the side effects will go away. And it does not screw with PSAs. Whereas Proscar and Avodart, that many doctors throw you on immediately, that's expensive. There's a whole bunch of side effects, and you need to take it 6 months to even work. So those 2 drugs are 2 completely different worlds. So ultimately, though, the underlying question is, do you really need Proscar over the other? That's the first I would just throw to you just as advice. But If you do, you're right. It drops the PSA on average in half. So if the PSA is 10, in a few months, your PSA drops to 5. And if you don't know that, or if you don't tell your doctor that, then your doctor who doesn't follow this is going to think you only have a PSA of 4 or 5 and may not catch what really is there. So very good question. It does play into this. I have to account for it.
Okay, go ahead, question.
Just a question. Do you recommend turmeric or curcumin to reduce inflammation or inflammation?
Okay, the question was, do I recommend turmeric and curcumin for BPH specifically? I recommend curcumin for pretty much everything else, because cancer and prostatitis are usually always involved. BPH specifically, no. However, I will say, though, that BPH usually leads to sometimes the inflammation, because if you have BPH and you're backing up urine, the urine causes a cystitis and maybe a prostatitis, so indirectly, I have to deal with it. So technically, no, but pragmatically, I tend to treat the inflammation from the byproducts.
Many of us are on ADT and your side effects from that. I personally have issues with sweating and chills also. And training we recommend for those who have sweating or very uncomfortable warm heat.
You're right. The true menopause. Right. Yeah. Well, there's obviously, I'm sorry, the question is, are there treatments, I'm assuming you mean more integrative treatments to deal with the menopause-like symptoms from androgen deprivation therapy?
Yeah, sweating and hot flashes.
Sweating and hot flashes specifically. Not one go-to. I know the two that work quite well, aside from, well, the three main ones. One is, of course, exercise, not to sound cliche, but it is very helpful. The other is acupuncture. There's actually been studies on that, peer-reviewed journal studies on acupuncture helping with hot flashes and such. And thirdly, I find most helpful is hydrotherapy. Contrast hydrotherapy, you know, saunas and baths, that works fantastic. Okay. Hydrotherapy is one of the most undervalued treatment. The reason I don't hear about it is because a doctor can't bottle it and sell it to you. Okay, it takes work to do it. When I went to college in Japan, I lived with the Japanese for a long time, and every day we took the hot bath called the oflo. And you would soak in the bath every day, and you come out into a house that had no central heating with the snow coming in, and your body, you'd be red from here down, and you'd feel like $1 million, and the circulation's up, the endocrine system is up, everything. And you go out, you know, you fall asleep immediately, and you have really strong dreams, your melatonin's up. I mean, doing that as part of your daily routine is one of the most important, profoundly healthy things to do. It's just hard to fit it in our American
Jacuzzi would work somewhere like jacuzzi?
Jacuzzi, absolutely, absolutely. Yep.
Okay, question here.
Yeah. If the philosophy that they're saying that the Gleason could be going up from 6, it could go to 7 or 8, how do they prove that?
Yeah, I don't know. This was kind of discussed at the last PCRI, and I didn't see the studies with it. But let me just. I don't know the exact, and I have to look this up. This is new. I have to tell you something, though, is that this is something, what I just told you is something I can't believe I'm even on tape talking about it, because I go out of my way to stop alternative people from making these claims like cancer's not a problem and it's not really cancer. And you're talking about going upwards from 6 to 7, but that is what's led to this issue that Gleason 6 may not be an issue. So I'm separating the issue. As far as Gleason 6, whether it's a cancer or not, that's something that I'm shocked that conventional doctors are talking about it. They're being forced, kicking and screaming to admit it. That's why I'm even bringing it up, because otherwise it sounds like something an alternative person that would say. But your question specifically, how does it go up? I don't know, because we didn't see it from what I understand in the Petri dish itself, but in vivo, in the person, apparently it did, and I'm not positive.
Let me just add a point here. Dr. Klotz, who's an expert on this situation, the DNA of the cancers are different between a 3 and a 4. They're very different, and they have different degrees of aggressiveness. They don't necessarily turn one into the other. But if you got some 4 in there, and that starts to grow, then that low 7 starts to take off. So it's an interesting research area. Okay, we got time for 2 more questions.
Okay, 2 more. I just want to comment one more thing, because the question that usually comes right after this, though, is what I thought your first question was, is, well, how do we stop it from going to 6 to 7? Because if the issue is that they can transmutate, then if you have a 6, that sounds good, but then you're still the boat, it can turn into a 7. And then how do we stop that? Because that's really what this is coming back to. And that, which is a whole other topic, which is the natural treatments and things that we all know of. The insults on the DNA that he's mentioning that can flip an oncogene and go from a 6 to a 7 or 7 to an 8. So that's where the inflammation issues come in, and stress, and all the things that we know seem to lead to cancer. Those we think may be adding insult to flipping these oncogenes and maybe upgrading these cancers. So it kind of, at the end of the day, comes back to those types of treatments. Yeah.
Okay, anybody over there? All right, you, sir.
A lot of talk and questions to you have been about things that people ingest in the form of pills, pharmaceuticals. Mm-hmm. I haven't really heard too much about diet, putting the responsibility back in front of us at the dinner place, sort of. Mm-hmm. Any thoughts on that?
Well, yeah. I mean, it's a large issue in itself. I would say that I know the ketogenic diet's been very popular of late with it. Low caloric intake has been found to be very helpful. Matter of fact, diet-wise, probably if you want to look for diet in general, you look for the anti-aging communities, because the anti-aging centers have kind of spearheaded much of this. I think one of the most important components is to lower the sugar and insulin ratio. And for those of you that don't know already, metformin, or from a natural perspective, berberine, cinnamon, watching that ratio is probably one of the most important things to do. People say, well, cancer only eats sugar. So I say, okay, well then so when they say that, I ask what they're eating, and they say, I'm eating broccoli and spinach, but that's all a sugar, right? It gets broken down into a sugar in your body, if you think about it. So what's the difference between broccoli and an M&M? I mean, obviously there's a lot of differences as what's in it, but really what it comes down to is how it's being introduced to the body. An M&M or Coca-Cola or apple juice, it get a spike of sugar, and then the insulin is the spike with it. And the insulin a lot of times can't keep up with the sugar, so it takes time for the sugar to slowly come down to the insulin, and then finally they both tack down to normal. Okay? But the longer that the sugar and insulin ratio is apart, that loose sugar is causing damage in your body. It's causing inflammation. That's why diabetics get, the erection issues and blindness and cholesterol. I mean, think about it. Why do diabetics that have high sugar in their arteries tend to get clogged arteries they have high sugar levels. Why do they have cholesterol buildup? If you think about it, they seem opposite. It's because the sugar in the arteries causes inflammation, which then the body takes cholesterol to try to heal it. So that inflammation going on in your body, cancer takes advantage of that, right? So, and any excess sugar, the excess sugar is what cancer will utilize. So the way to starve the cancer really is to make sure that the sugar and insulin ratio is as tight as possible. And guess who's figured that out? The anti-aging people. Because they're trying to refine, like Olympic athletes and Burt Reynolds and those guys, the anti-aging centers in Vegas, people pay a lot of money for them. But the idea is to try to reduce that ratio as much as possible. So how can you do it? I'm going to give you the basics here, but you can look on the lef.org. I have a lot of respect for that group. Life Extension Foundation, for those of you who don't know. Things like eating foods with low glycemic index, bam. Number 2, don't eat one giant meal at the end of the day. You can eat even more calories as long as you spread them out in small meals like the Japanese do, right? So it's a slow, like sustained release capsule of food versus a spike all at once, right? You see how that works. Eating foods that are high in fiber, okay? So that slows down the glycemic index as well. Exercising a little bit after you eat, because when you exercise, you burn off some of those calories, just like kids after Pop-Tarts running around outside. If you eat and then you exercise a little bit, it helps burn off that sugar again. and metformin, which is why a lot of doctors are starting to understand this. The FDA is looking at right now, they're looking at a second approval for metformin as a cancer medication. They really are. And it's been about 5 years that's still under study. Any day, Dr. Oz is going to talk about it and everyone's going to know about it. But right now, doctors are all like popping them like in the back in the parking lots themselves. So that's what they're doing. And at one of the PCRI conferences I went to, one of the doctors kept getting, everyone in the audience, well, what about metformin, this and that, and what do you think this? And he said, look, let me just tell you what I do. This is what this other doctor said, an MD from a cancer center. He said, this is what I do. He says, when I see a new patient, I shake his hand with the right and I put metformin in the left. That was his quote. No, I'm not trying to say that, I'll need to go run and do that. I know I'm a naturopath and all this, but the metformin is a pretty good safety record for what it is and a lot bang for the buck, and it's cheap for a lot of guys on fixed incomes. If you don't want to go that route, berberine and cinnamon and make sure you exercise along with it is a very good alternative, okay?
What is metformin?
All right, one last question.
Metformin's a diabetes drug.
It's the farthest question. You go ahead.
Yeah, I got a question. There was a gentleman that talked about focal cryoablation last week. Is that pulling the ripcord, or is that, what I'm thinking is, in my own case, I'm 75, I'm thinking that if I do this, maybe it'll slow the process down. Maybe I won't need radiation I can get an extra 4 or 5 years. I doubt it's a cure, but it might slow the process down.
Yeah, well, I mean, it depends on the case, but cryoablation is meant to be a definitive treatment to some degree, and it depends if it's the entire prostate or focal as well. But no, it's considered a treatment, and if they think, and it depends on the case, but if the lesion seems localized enough and contained, then you may have cured the whole thing or bought a certain number of years, and that's why tracking afterwards is very important, of course. So it kind of depends on the case there. Yeah.
All right, let's thank Dr. Tamburri for a wonderful presentation.
Thank you.